Altered Physiology, Mechanisms of Disease 2. This is a continuation of our lecture on the alterations in the respiratory system. Here in episode 5, we will start to discuss some of the common pulmonary disorders, and we will differentiate whether they are restrictive lung diseases or whether they are obstructive lung diseases. So here on this first slide, we characterize a few of the restrictive lung diseases. And once again, these are diseases where you have limiting lung volumes, whereas with obstructive diseases, which we will get to in a moment, that includes those conditions where you have limiting airflow. Bronchiolitis is an inflammatory obstruction of the small airways. It is once again, due to inflammation. It is most common in children. It can occur in adults with chronic bronchitis or in association with a viral infection or with inhalation of toxic gases. Pulmonary fibrosis is another restrictive lung disease. It can be idiopathic in nature, and it is when you have excessive connective tissue in the lung that diminishes lung compliance. So it is also associated with chronic inflammation. Now moving on to obstructive lung diseases. So obstructive lung diseases, once again, are associated with limiting airflow. They are characterized by an airway obstruction that causes difficulty, particularly with expiration, so when you're expiring air. Notably, the obstructive diseases can be acute or chronic in nature. Common examples include asthma, COPD, emphysema, and chronic bronchitis. And so there's a schematic diagram in the bottom right that highlights in particular COPD, also known as chronic obstructive pulmonary disease, talks about some of the symptoms, and it also highlights the idea that COPD essentially includes the combination of chronic bronchitis and emphysema. So we're going to go into a little bit more detail on each of these obstructive lung diseases. First, though, we'll start with asthma before working our way back to COPD. So on this next slide here, what you can see is that we're looking at asthma, once again, characterized as an obstructive lung disease. Now, it is a chronic inflammatory disease of the airways. It results from a type 1 hypersensitivity immune response involving the activity of antigens, immunoglobulin E, mast cells, eosinophils, and other inflammatory cells and mediators. In asthma, airway obstruction is associated with attacks that are intermittent in nature and involve bronchial spasm, bronchial inflammation, mucosal edema or swelling, and increased mucus production. Individuals will experience symptoms such as wheezing, dyspnea, which is also referred to as shortness of breath, or tachypnea, which is the increased rate. Now, what you can see on the far right of your diagram is that typically these episodal attacks of bronchial spasm will be triggered by an allergen or irritant. And so it leads to an immune response with the activation of several interleukins, as well as immunoglobulin E production, as I've highlighted previously. Now, there are a number of symptoms that can present, and these are highlighted in blue on the flow diagram. As I've mentioned, bronchial spasm, mucus secretion are common. You can have a thickening of the airway walls as well. And essentially what happens is you have an airway obstruction that is particularly notable, once again, on expiration. In the diagram or figure on the bottom right of your screen, you can actually see a normal airway versus an asthmatic airway versus an asthmatic airway during one of those episodal attacks where bronchial spasm is occurring. Next, I will highlight emphysema. This is one of the two conditions that is present in COPD. It is also classified as an obstructive lung disease, meaning that there is difficulty with expiration, particularly, once again, a limitation of airflow will ensue. What happens in this case is that with emphysema, you have a permanent enlargement of the gas exchange airways that is accompanied by a destruction of the alveolar walls without evidence of fibrosis. The alveolar enlargement is second due to a loss of passive elastic recoil, which we have spoke to in terms of in preceding lectures about lung and chest wall compliance. But once again, elastic recoil is going to contribute in this case to emphysema. Individuals can also experience airway collapse and an obstruction of the gas flow and air trapping during expiration. Individuals may have an inherited deficit of alpha-1 antitrypsin as well. Now, COPD. So once again, COPD is also an obstructive lung disease. It is inclusive of chronic bronchitis and emphysema. It is characterized by persistent airflow limitation, and it can progress over time. It is one of the most common lung diseases in the world. It is also an important cause of hypoxemic and hypercapnic respiratory failure. So lower than normal oxygen levels and at the same time higher than normal CO2 levels, resulting in respiratory failure. You can have a look at the schematic diagram on the far right of your screen, once again highlighting those environmental irritants which can contribute over time to the progression of this disease. So COPD would be common among those individuals who are tobacco smokers. It can also present in environments where air pollution is a significant ongoing concern as well. It once again is associated with inflammation of the airway, and that triggers an inflammatory response with the cytokines and a number of different mediators as well. What you can see downstream, though, is once again, it is characterized by both chronic bronchitis and emphysema, leading to an airway obstruction, and it does present with a number of symptoms as highlighted on the screen, including shortness of breath, coughing, low levels of oxygen, high levels of CO2 as well. We'll conclude this lecture episode with a couple of checkpoint questions. So which of the two is, which is true regarding the pathophysiology of asthma? That is checkpoint question 2. And what we're looking at is the correct answer being C. And so inflammation will result in hyperresponsiveness. And so once again, asthma is caused by an increased bronchial smooth muscle spasm and increased vascular permeability. Immunoglobulin A is not the major factor, so that one is not correct. It would be immunoglobulin E. Answer stem B is incorrect because there's actually an increased vascular permeability. And inflammatory mediators will cause vasodilation, increased capillary permeability, mucosal edema, and bronchial smooth muscle contraction or bronchial spasm, and mucus secretion as well, all contributing to an obstruction to airflow. So answer D is not correct as well. Now, last question. So checkpoint 3. A patient has a history of emphysema and hyperinflated lungs, which would be true. In this case, it is answer A, that there is an increased lung compliance and decreased elastic recoil. Notably, airway resistance refers to the opposition to airflow and is determined by length, radius, and cross-sectional area of the airways. Surfactant will affect the surface tension and alveolar ventilation. And that concludes this lecture episode.